Greg, you're muted. We can't hear you.
Apologies again.
There we go.
Yes, I'd shot myself in the foot by saying that my children pinch all my computers when they do their exams, and I get left with the what's left over. And then yes, I went and suddenly froze on me. So if it happens again, I apologise. I will get back on. I will pinch one of my daughter's computers to get back on. But no, I work within 3 consultants, 2 registrars, physician's associate, myself, and a staff grade registrar within the orthogeriatric team on a hip fracture dedicated ward in University Hospitals Plymouth NHS Trust, which is at Derriford Hospital. And I'll get straight into the presentation so that we're not short for time at the end. Hopefully that will come. Oh no, not that one. Excuse me.
Oh, just one brief thing I forgot. Please put any questions you have in the chat and we will endeavour to get them asked at the end of the presentation. Sorry, thank you.
Okay, is everybody able to see that? Yep. Good. Right, let's get underway. Okay, so the reason I've presented this in the context of delirium is it's very difficult and very boring really to put a bunch of numbers on the screen and verbatim just quote, this is the high number, this is the low number, this is what we would expect. So I'm trying to put it in the context of those issues that I experience or physios on the ward will experience in a day-to-day. And the 2 things that the big topics that are certainly in the hospital where I am is that of delirium and its effect on the patient and how we manage it, and what are the sort of biochemical abnormalities that might suggest a cause of this. And the second part really is to look at where we are in terms of hemoglobin. And there's a little bit of fear around mobilization with levels of hemoglobin and how we look at the evidence to say what is a safe level to mobilize. So we're going to do a review of delirium, and I know a lot of you will be very familiar with that, so we'll try and push through that fairly swiftly. We're going to look at biochemical derangements in the context of perioperative care, and if somebody asked me what is your role on the ward, it would be perioperative medicine or perioperative care. Certainly the element of physiotherapy, pure physiotherapy that I do, is certainly very distant now. The third part is, what do I do with a low hemoglobin? How do we put that in context of a hip fracture, which is my speciality? Looking a little bit about volume loss, and look at the evidence and national guidelines for hemoglobin and mobilizing and safe mobilizing in a variety of clinical settings. So with delirium, a lot of you will be very familiar with delirium, or an acute confusional state, characterized by disturbed consciousness, cognitive function, and perception. And the keys here for delirium: it has an acute onset and a fluctuating course, something that's obviously very different to dementia. It's very serious, and very serious in the group of patients that I work with, and we'll go into the reasons why. It can be mistaken for dementia, but as I said, it develops quickly. It's usually temporary, but can last and form a new baseline for the patient when they leave hospital. So as I said, it can be difficult to distinguish between both, and again, it's acute and fluctuating. But the statistics are quite alarming, really. So those that are having surgery, so the fractured hips that I see, up to 50% of them will suffer delirium. And this can be pre-op, it can be post-op, it can be 2 to 3 days. It can evolve over a period of time, depending on what the stresses are on that patient, both physically, mentally, biochemically. The reason that we're so worried about it, we know that it's a significant healthcare burden. They need to stay longer in hospital. Increased incidence of dementia, and there's this seesaw between that dementia. Those people with dementia are more likely to develop delirium, and those people who suffer with delirium in hospital are more likely to develop dementia in later life. Later life, we say later life, they're all over 65, it's getting later and later. More hospital-acquired complications, falls, pressure sores, UTIs, are more likely to be admitted to a long-term care. So all those aspirations we have and the sort of length of stay and returning to previous independent living are threatened if they're suffering with delirium. And of course, it's associated with increased mortality. In terms of hip fractures, we know that between 5 and 10% die within 30 days, and up to 30% die within 1 year, and 50% will die within 5 years. You add on the burden of an element of delirium with that, and of course the mortality is going to increase. So it's something that we've got to be very careful about and astute to responding to. So types of delirium: hypoactive versus hyperactive, symptoms or signs of hypoactive, poor concentration, more common, although it attracts less attention than hyperactive, because hyperactive is a burden that demands a lot of nursing time, bed watch, bay watch, etc. But hypoactive, increased length of stay, increased risk of deterioration, and associated with increased mortality over and above that of hyperactive. So hyperactive can be seen as confusions, hallucinations, sleep disturbance, less cooperative. We know that to have that diurnal disturbance where they're awake all night and they come and then asleep all day, and you come into the ward and say, "Oh, how has Mrs. So-and-so or Mr. So-and-so been today?" And they say, "Oh, they've been absolutely fine since we came on, but they're awake all night." And so you have a relatively better day, but during the night they've had a horrible disturbed night. So increased length of stay and greater distraction, time allocation, bed watch we've talked about. I don't know what that can people see that red line there? No idea what that is. So assessing for delirium. If people haven't come across the 4AT, we're looking at the patient's alertness. Are they awake during the assessment period? Or are they more drowsy? We do a brief 4-8, the abbreviated mental test score: age, date of birth, place, and year. Their attention, and if people haven't done this, you'll be doing this as I speak about it, but you may well hear the orthogeriatricians on the wards asking them to name the months of the year backwards, starting with December. And you'll probably be all doing that now in your heads. And actually, sometimes it's more difficult than you think. So and is it acute change or fluctuating course? And this is where collateral history is really very important to establish whether or not it's a baseline for the patient. Just going to see if I can get rid of that. No. No. Okay, and that altogether is the 4AT, and it's recognised. You'll be able to, you can get an app to download for a 4AT score, and it gives you a fairly good idea about how well the patient is behaving, and it can determine a fluctuating course, so you can use it to monitor your patients. Okay, so the risk factors precipitating events for delirium are many. There is a mnemonic you can use called Pinch Me, and you can look that up at after any time. It's a useful mnemonic in order that you can look at what's influencing your patient, what might be causing delirium within the patient. So risk factors: over 65. All my patients are over 65. Have they got a pre-existing dementia, cognitive impairment, Parkinson's disease, stroke? Have they got a vulnerable brain? Frailty, injury, trauma, including head injury, and many of the patients will have a CT head when they come in. Have they got a functional impairment? Have we created iatrogenic events by over analgesing with opioid analgesia? Or are there certain medications that have recently changed that have precipitated an event? Alcohol excess, unfortunately very common in this group of patients. And with the withdrawal symptoms, using a CWAR score, it's often can be a cause of delirium. So there are many reasons that these might be multifactorial within these patients. But what we're going to talk about, obviously, today is which biomechanical upset might be a cause of confusion. So here we have a list of what we might be looking at. And on your screen on the left-hand side, these are the sort of common admitting drugs, blood tests that are done, and the common reasons. And we're going to go into these individually and explore them a little bit further. But when we look at the results of these patients, these vulnerable, frail, elderly patients have a very small physiological range that they can tolerate. And any insult outside of that, so we're all familiar with the very commonly used, UTI, they decompensate very quickly. So poor tolerance of derangements within this small physiological range, whereas you and I can cope with a cough, cold, injury fairly easily. On the right-hand side, the confusion screen, that's what we may choose to add on to blood tests when we've got an unexplained, or we've got a delirium that's evolving either preoperatively or postoperatively, and we want to exclude other derangements within their blood tests to rule out deficiencies or derangements. So let's go and have a look at the first, which is the full blood count. So hemoglobin, white cell counts, platelets. Platelets don't really have a great value in looking at confusion or delirium. We know that hemoglobin values greater than 120 in women, 130 in men. The blood test may well, with a mean cell volume, might differentiate the anemias. So it's micro small or less hemoglobin, low iron, macro larger and frequently fewer, with poor maturation stage of the development of the red blood cells affecting their, and the DNA synthesis is affected due to low B12 and folate. And so that's a macrocytic anemia. Now, low hemoglobin itself is not directly associated with confusion, but it's a subject that we're going to come on later in the presentation. White cell count, this is a marker of inflammation and infection. but it's very common to get a rise in white cell count, a reactionary after injury, and certainly post-operatively. So it wouldn't be unusual with a normal white cell count of less than 10 to get a white cell count approaching 20, sometimes higher than that post-operatively. And that's why you must treat in the context of your examination. And if you're concerned about an infection, then the first thing we do is a septic screen, including, and the common things are common. So think urine, chest, wound, and finally, biliary sepsis. So these are all things, and we'll again, all the way through, that are constantly within your mind and your clinical reasoning as you're looking at the panel of blood results, plus your patient in front of you. One other thing that we'd see is B12 and folate, as macrocytic anemia is a very common deficiency seen in alcohol related disease or chronic alcohol consumption. So electrolytes. I've got the normal and the common sodium there on the left and the potassium. There are so many things that can cause electrolyte disturbance. It's quite incredible. Decompensating conditions. And so we've got acute kidney injury, chronic kidney disease, acute kidney injury being a pre-renal, an intrarenal, or a post-renal effect. And we measure the serum creatinine rise, a specific calculation, and creatinine is a waste product from muscle tissue protein breakdown. And if it's not filtered well in a poor functioning kidney, then that gives you the indication of an acute kidney injury. Heart failure, drug therapy causing decreased kidney function. So hepatorenal syndrome, cardiorenal syndrome, reducing perfusion of the kidneys and causing further insult and acute kidney injury. What that does is give a rise to your electrolytes or a deficiency in electrolytes. And one of the, again, one of the symptoms of that will be confusion. So adrenal insufficiency, poor cortisol, poor glucose control, poor sodium regulation. Your adrenal causes your autoimmune and your glucocorticoid use, your pituitary issues, and your pituitary axis, which is your aldosterone regulating your electrolytes. And drugs that affect this are such things as the diuretics, the ACE inhibitors, and then a very common one, symptom of inappropriate antidiuretic hormone, where your ADH suppresses the release of water via the kidneys. And so you either get increase in water retention, which dilutes the blood, or secretes more sodium out of the kidneys. So you've got this, again, another cause for electrolyte balance. And of course, very obvious diarrhea and vomiting, where you're losing acidity regulation, which has to be replaced from somewhere. So getting potassium, sodium, magnesium imbalances. So consequences of electrolyte extremes. We've got hyponatremia. And when we looked at that range, if we go back and look at that range of 134 to 146 and potassium 3.5, just keep those in the back of your mind. Elderly people can generally tolerate quite a lot of loss. And when I started this job, I used to get so worried about low sodium, so worried. But actually the tolerance within this group of patients is actually not too bad. The problem is differentiating where, if they have a delirium at the time, how much of this is hyponatremia or other derangements. So hypernatremia, which is relatively uncommon, but can cause confusion. Hyponatremia is much more common. Hypokalemia, so potassium of less than 3. Again, it's less common to suffer any confusion with this, but it's very important in terms of the potassium in controlling potassium and calcium in controlling heart, muscle contraction, myocardial arrhythmias are the worry here and a significant cause for action. Hypocalcemia, again, normal is 2.1 to 2.55. Confusion, muscle cramps, myoclonus, and again, cardiac arrhythmias. And within those last two, protection of the heart is the most important part. And again, I've never seen a potassium or calcium disruption that's caused confusion, but plenty of hyponatremia that's caused or been a potential for a cause of confusion or delirium. Okay. So we talked earlier on about looking at a confusion screen. So again, where we get derangement in these electrolytes, particularly calcium, folate, B12, and LFTs are the ones we're most interested in. So calcium and phosphate, arrhythmias, muscle weakness, confusion, bone pain, but that's a chronic issue. B12 and folate, they're neurological and have a big influence in memory and cognition. So when we're deficient in B12 and folate, they're needed in the synthesis of neurotransmitters and other brain chemicals. And so deficiency of this can add to an already, or a picture already of delirium, vulnerable brain, and can be quite significant changes in a patient's cognition on the ward. So thyroid stimulating hormone, TSH, is almost always acutely deranged. Both an increase and decrease can be associated with memory and concentration issues. However, with an acute insult, such as a hip fracture or admission to hospital with a medical condition, they are very commonly deranged, and almost always we ask the GP to check this 6 weeks later once they're over an acute insult. LFTs finally there. If we've had a reduced perfusion to the liver, we've got deranged LFTs, and we've got poor liver function. So we've got an increase in toxins, particularly ammonia, which can cross the blood-brain barrier and add to confusion. We'll often get an acute derangement on post-op patients, and again, it's about managing this in context. I have to say that the hepatobiliary team don't get particularly excited with acute derangements. If they're persistent and don't return to a baseline within a week or so, then it might be that things like, or if they're significantly escalated, then it might be that we order an ultrasound liver. Again, it's the magnitude of their derangement and the speed at which they change as well that's more concerning, both with all the electrolytes we've talked about. So we've got a magnitude change and speed of change, and that's a more concerning feature. So refeeding syndrome, not unusual that we have to monitor it. It's unusual to get it, but it's not unusual to have to monitor it. So we have a patient who hasn't eaten a great deal, then in order to maintain serum electrolyte levels, then electrolytes exit the cells. And while this is going on and the patient is in a starvation mode, many people do it during a diet. The body will use protein for energy. Then when the patient perhaps gets over an acute delirium and we manage to get some food inside them, whether that's an Ensure Plus or some Ames protein soup or energy food, when glucose is increased, the intravascular electrolytes are pushed back. Potassium, in particular, they're pushed back into the cells under the influence of insulin. Phosphate goes back into the cell for ATP production, and therefore the electrolytes that were busy keeping a nice balance within the serum get pushed back into the cell, and we get a serum deficiency. And again, this can cause your electrolyte balance. And another thing that can happen is what we call vernix encephalopathy, where thiamine, which is used in the metabolism of glucose, and hence there's a depletion when glucose is reintroduced. We get a thiamine deficiency, confusion, and can lead to a vernix encephalopathy. So that's again why we use this CWAR score in withdrawal and starvation. Right. So that's a picture in context of confusion and electrolyte disturbances and blood tests that we look at, but have a great tolerance to, but a high degree of suspicion, with plenty of investigations going on in that acute phase post-operatively. What I'm going to look at next is hemoglobin levels and volume depletion. Another, again, concern that about 2 years ago reared its head within the department, that it seemed that physiotherapists were coming through, whether it was training, whether they'd come from other hospitals, and it became apparent that physios, and I think there's a great variety, but within the hospital where I worked, there was a great caution about mobilizing patients with low hemoglobin levels. And so what I did was explore this with them a little bit and looked at the latest evidence, which I'm now going to present to you. So this is the NHS UK public domain, their definition of iron deficiency. And within there, the symptoms, they say, can include tiredness, lack of energy, shortness of breath, noticeable heartbeats, heart palpitations, pale skin. What it doesn't include in there is dizziness. Now, dizziness was a big block to mobilizing on the ward. And it seemed that the physios were attributing this, if they came across somebody with a low hemoglobin, it's something they were attributing partly to that. And fortunately, it's relatively uncommon in anemia. Now, they're talking here about iron deficiency anemia, but anemia in general, 3% of women internationally and 8% of men in the general population. But as you rise to over 65, anemia is present in 10% of people and in 30% in over 85s. So it's a very common presentation to everyone, whether you're inpatients, outpatients, acute or elective. And of course, in elective surgery, this can be managed very well in preoperative clinics and preparation for surgery. But in the acute presentation, it's something that can't be managed immediately other than by blood transfusions. So we're going to look at the causes of postoperative anemia in hip fracture. Again, that being my speciality, and looking at intracapsular versus extracapsular versus femoral. So preoperative anemia with hip fractures, interestingly, is more common if patients have an extracapsular or femoral fracture. If you have an intracapsular fracture, then the blood loss is tamponaded by the hip capsule and doesn't tend to bleed as much. Extracapsular, it will keep bleeding, and you'll get quite a lot of swelling within the thigh, and it doesn't get tamponaded. The same with femoral fractures. So for a pre-op anemia, again, including chronic kidney disease, anemia of chronic disease, where production of EPO in the kidneys and bone marrow suppression can be evident. Intraoperative blood loss, again, a nail, a femoral nail, will create significant blood loss. Hemiarthroplasties less so, but they've got to do a larger incision in order to dislocate the hip, and they've got to ream the femur. So again, much more blood loss there. If you've got a DHS, it's a very small incision. The hip isn't dislocated and it's fixed in situ, so there's very little blood loss. But the average blood loss for something like a DHS is between 200 and 400 millilitres, rising to about 500 to 600 for a nail. So post-operatively, inflammation, infection, sepsis, clotting or lack of clotting, connected with VTE prophylaxis. So we're giving them Plexane, or Inhixa as it is now, which can cause thinning of the blood and poorer clotting. Intravenous fluid in the sort of perioperative period. If they're nil by mouth, we're giving them fluids. When they're in theatre, we're giving them fluids. They're losing blood. And then post-operatively, if they have delirium and aren't rehydrating well, we're giving them more fluids. And what that will do on the background of blood loss will hemodilute. Bleeding, ooze, hematoma, and then the risk in decompensating patients with a gastrointestinal bleed. We're giving them, again, VT prophylaxis. Patients who have previously been on antiplatelets or been on a DOAC. So there's significant risk of further blood loss in these patients. And so how do we manage them in this perioperative period? And for the patient, there's an increased cardiac demand with the stresses of the injury, the theatre time, or injury, the long lie, possible tissue hypoxia. They nearly all have lower blood pressure post-operatively. There's plenty of risk in terms of how much demand they're putting on the body and how much they've been robbed of this essential red stuff. Clinical audit done 7 years ago now by myself and one of the registrars noted that 50% of our patients were anemic perioperatively, on admission. And again, that's reflected in the literature between 40 and 50%. And so this was even before they'd got to theatre. This was in the clinical audit was in precursor to looking at the prescription of IV iron and administration of IV iron to do with other projects that were ongoing. So what can we do for these patients? We can pre-op optimization. We can give them IV iron or oral. Again, that's not legitimate in or not used in acute pathways because it's not going to have any effect whatsoever. So our main ways that we can manage anemia are with cell salvage and TXA. Post-op blood cell transfusion is fairly common, with about 20% of patients receiving. Now, so in many centres or in many trials, they've used a restricted versus liberal regime, and these are many. We'll come to a couple of examples within the literature coming up. But the red cell transfusion is mainly, and the guidelines with NICE and CPOC will come to in a moment. So this is an article, a review article. It wasn't primary research. It was about developing a checklist, a clinical reasoning algorithm to look at what was safe in terms of mobilizing acutely ill patients based in acute medicine. And it's interesting in the fact that, again, nearly all of these articles look at, or these papers that I've looked at, qualify, while there are no absolute lower values for hemoglobin, precluding mobilization. An acute fall in hemoglobin can indicate active or recent bleeding and may delay mobilization, particularly if accompanied by hemodynamic instability. And I've underlined that because I think that's the real crux of the argument that I have for not restricting mobilization based on hemoglobin levels, in that it's a hemodynamic instability. And the reason we get that hand in hand is that we've got a volume loss. We said about perioperative blood loss. And it's that, rather than the concentration of the hemoglobin, that causes the issues. So again, we do recognise on the left the article stating a well-known research finding that anaemia is independently associated with poor outcomes, including length of stay. And that's what we get very concerned about a low hemoglobin, is that it's a predictor of very poor outcome. What is not clear is that if we pile them full of blood, so even if they've got a hemoglobin of in the 90s and we give them blood, or if it's less than 70 and we give them 3 units, there's no conclusive evidence, and that is borne out on the article on the right, that transfusing doesn't seem to improve the ambulation scores. So although we say that it is a predictor of poor outcome, by transfusing liberally, that is with even if they've got a high or relatively high hemoglobin, let's say between 87 and 98 there, it doesn't show an improvement in the ambulation scores. And of course, with transfusing, there's a risk of iatrogenic events, transfusion reactions, and lung injury. So at the moment, there's something called the Popeye trial going on that's looking at the levels of looking at giving IV iron and EPO in hip fracture and some laparotomy patients, and seeing whether the outcome definitively is that IV iron post-operatively can have a beneficial effect. That's ongoing, and they're still recruiting in that trial, possibly for another 12 months. Again, here another one, so physiotherapy in the intensive care unit. So this was, again, a guideline, so what it's an expert-driven practical statement and rehabilitation recommendations, where they identified clinically relevant questions, did systematic literature search, summary of the evidence, and then moderated by feedback from experts. They drew up this checklist that would enable them to be confident in mobilizing patients post-procedure or on intensive care. And if you look down that list of there's not one place in there, and there wasn't one place in the article that they talked about a hemoglobin level. So conspicuous in its absence almost. No mention of hemoglobin. The next article, again, very oncology related, and these guidelines were developed from a literature review and consensus statements taken from them. So 3/4 of the articles obviously are oncology related, but the other third are probably, the other quarter are probably method orientated or articles that I've featured here. So there's not a wealth of evidence around this subject, and it's very difficult in that it's quite niche. The mesh headings are often very very varied. So the hit rate is relatively difficult to achieve. Let's nip on to the next one. So this was quite an interesting article that helps the case to support you in your argument for, or your confidence in mobilizing patients despite a low hemoglobin. So the impact of low hemoglobin on the percentage of adverse events during the physical therapy in the acute care setting. So out of over 3,000 patients, 448 were identified as having an adverse event. And adverse events were systolic BP greater than 200, relatively uncommon. SATs less than 90. Systolic BP that drops more than 10 milligrams of mercury, millimeters of mercury below resting with activity. And bear in mind that some of these patients have a blood pressure of 95 when they return from theatre and day one post-op. Symptomatic orthostatic response, defined as systolic BP dropping greater than 20 millimeters of mercury, or a diastolic BP dropping greater than or equal to 10 millimeters of mercury, or heart rate increasing greater than 120 beats per minute with activity. And the number of people who have AF post-operatively, that's common as well. So out of 78 sessions where the hemoglobin was less than 80, 5 of those patients, or 6.4%, had an adverse event. So with a hemoglobin of less than 80, the incidence was 6.4 out of 78 sessions. So it's a very, very low number. So 448, but only 5 out of 78 with a hemoglobin less than 80 had adverse events. So that's quite a good article to support. It's still 10 years old, but it's about the most relevant article that there is out there, looking at the concerns we all have when we first get a patient up out of bed. So looking at guidelines.
So sorry. We have about 10
minutes left. Yeah, that's fine. Thank you very much. So again, recommendations from the ACP, in respiratory care, sorry. Again, might delay mobilization. They cited the other paper we've already said this evening. And there where it says HTCs, that's hospital transfusion committees, they generally follow a guide of below 70 or a transfusion threshold of 70 in most patients and 80 if they've got a cardiac history. So CPOC, again, very much in the arena of please mobilize these patients, not according to HB levels, but on symptoms. That's shared an opinion shared by the National Hip Fracture Database, and they're unanimous that hemoglobin should not prompt a question of whether to treat or mobilize or not. The slide again quickly on volume depletion. Again, this is related to low volume hypotension. Pre-hospital, these patients, and this is across the board, they have poor intention to drink with dementia, UTIs, infection, they've got a pyrexia, they've had a fall, long lie, they're frightened to wee whilst immobile, they've had blood loss while they've been lying, they've got poor oral intake, they don't like going to the toilet at night, they don't drink. And so we know that these patients are relatively underfilled for a lot of the time. They have poor oral intake, waiting for ambulance, they stay in the ED. Again, their volume deplete when they get to us. Perioperative, they're nil by mouth, they have blood loss, they've got pyrexia, losing fluids, DMV. Again, they're poor mounting of cortisol response in the elderly, leading to lower blood pressure. Again, my plea is when you see patients on the ward, if they don't normally drink with a straw or a beaker at home, please try and take that top off the beaker or take the straw out. If they're not used to that, they're not going to use it, or they're less likely to. So just a final slide on the summary of the hemoglobin and whether to mobilize. It's a small body of literature that I can find that acknowledges caution with low hemoglobin, but again, it doesn't enforce strict thresholds. And it doesn't support the culture of using an HB of less than 80, which is common out there in the literature as an exclusion to mobilize. And certainly at our hospital, and it'd be interesting to hear whether many of you out there have come across the same experience. And looking in sort of your policies within the department. So volume depletion is common post-operatively. And symptoms of this are dizzy, are orthostatic hypotension. But again, we have been historically associating this with anemia. And I think that that is something that we've got to, if it's out there in your practice, we've got to come around to changing that and understanding a little bit more about orthostatic hypotension. The evidence suggests that we should be reassured in mobilizing patients unless there's a hemodynamic instability. And yeah, just giving you the confidence to do it in the context of, you know, stable observations. So, sorry about that whistle-stop tour, and sorry about the delay to starting, but I do want to invite some questions if there are any. But it's very common to find derangements in routine bloods. They're very well tolerated and rarely treated in isolation, and building up a clinical picture, taking in the patient's history, any acute insults. They can lead to confusion, but normally in their extremis, so very high or very low, and then persistence. And it's whether or not it's the rate change and the magnitude change are more commonly associated with it. Many common comorbidities that we went through can be responsible for the derangements, and many patients carry a high comorbid burden. And when they decompensate, then that's when the trouble hits. And this, again, presenting as a delirium or a confusion and trying to unpick the problems. And finally, that hemoglobin of less than 80, not a contraindication to treatment, and volume depletion rather than hemoglobin loss is a much more likely cause. So that's come to the end of it. Are there any questions?
Hi there, Kenny here from Agile, just having a look at some of the questions here. There are a couple feeding in here now. I've got, and you might have touched on one, but can acute kidney injury or chronic kidney disease cause delirium directly?
Say again, sorry, can you repeat that?
So from Mathili,
yeah,
she asks, can acute kidney injury or chronic kidney disease cause delirium directly?
Yes. So within an acute kidney injury, you've got to think about what the cause of that might be. So lots of that, if you've got an acute kidney injury, you've got a lack of perfusion to the kidney. So you've got a lack of perfusion and you've got a lack of hydration. So you've got to think about what causes those two elements to happen. So if you've got a pre-renal, have you got an obstruction? Have you got a hydronephrosis? Have you got a blocked catheter? Have you got a UTI? So all of those things can precipitate a delirium. Again, it's multifactorial. If you're talking about acute kidney injury, there will be a derangement of something happening. It might not necessarily be sodium, potassium, it might not be the electrolytes, but you might have a sepsis that's creating an acute injury. You might have you might have a lack of perfusion, creating a terrible GFR, but it's caused by other means. But when you then look in your blood results and it says AKI 1, 2, 3, whatever it might be, it's the cause of that that's then causing the delirium. Does that answer the question? I hope.
Hopefully. And we have another one here. We got one from Precious. Is there a definite number, level of rising CRP and WCC numbers, which may indicate an infection and septic screen required?
No. And the CRP is an acute phase reactant and will be increased by injury. It will be increased by infection. It will be increased by operation. So that either of those in isolation will not give you the answer. There's not a level. The higher they are, the more worrying they are. Absolutely. You'll find that post-operatively in a hip fracture patient, we will not order a CRP. So if the patient has come back and let's say they've just had a hip fracture repair, they're back from theatre, they haven't got delirium, and you ask the patient, are you weeing all right? And they say it stings when I wee. Your CRP might represent, there's no point getting a CRP because it will be elevated because of the hip fracture. So you would then treat that, you treat that empirically, in that they have symptoms of a UTI and treat. You'd send off your urine sample. But post-operatively, they're very deranged. Both the white cell count can be, normally it will be post-operatively between 12 and 17, somewhere around that ballpark. The CRP might be in the 200s post-operatively. But no, there's not a definitive. If you've got you and I, if we've got a white cell count greater than 10 and a CRP greater than 10, then there's something to think about. But within an acute, frail, elderly, falling group of patients, there are no definitive levels.
Thanks, Greg. And I think we've run out of time. There's a couple of more questions in there, but I think we may have run out of time.
I mean, maybe we can put these questions on a sheet of paper, and if you could just maybe see if there is a response that we can maybe put onto the website or to the YouTube channel.
Yeah, but if people want to contact me by email, that's absolutely fine.
Perfect. If we could go back again, I just want to quickly run through. My name is Ritu. I'm part of the Agile East Committee, and I'm also part of the National Committee. And I just wanted to thank everyone for taking this time, to join us. It is quite a challenging topic, I think. You've done fantastically well to cover a lot within a short period of time. It's definitely not easy. It's quite a tough task to understand all of those bloods in a short period. But as Adrian mentioned previously, the slides are going to be on the YouTube channel, so you could have a look at it. I just wanted to kind of encourage everyone, those who are Agile members, we're trying to get some information about the demographics of our members, so that we can keep promoting the inclusive culture and celebrate the diversity that exists within our group. So I would be grateful if you could either scan the QR code or the link is at the bottom. If you could complete the survey, that would be really, really helpful. Could I ask you to go to the next slide, please, Greg?
Yeah.
So this is just telling you what Agile does. Most of you or many of you might be members of Agile already, but we are a group of physiotherapists that work to try and promote the high standards, whichever field, wherever we are, to try and work for our older adults by promoting education, research, efficient service delivery. We look into all of those. We help people. If you're interested in doing any sort of research work or audit work, we have a little bit of an education fund that we could help people that may be related to courses or conferences and things like that. So there are loads of benefits in joining Agile and being part. And obviously you get to be part of free webinars like this one. And then the last slide, please. And we are looking for looking for a few people to join our national committee. There are a few vacancies. People have really worked hard over the last few years, and they're going away now to do to different areas. But we'd be very grateful if there is interest amongst people to approach us and express your interest if you are interested in any of these roles. All I can tell you as a treasurer working within the National Committee is that it's an absolutely fantastic group of physios with loads and loads of experience and loads of support. So if you are interested, please do contact us. But yeah, thank you very much, and sorry for running over a little bit, but hope you found the evening useful for you. Thank you. Thank you, Greg.
Yeah, thank you very much, Greg. It was really great. Thank you for presenting.
Pleasure. I hope it wasn't. Yeah, I realised there was a lot to pack in there, and I cut out a lot of slides. So, but if people do want to ask me individual questions, either about my role or about any of the subjects that I've talked about this evening, then I'm more than happy to be contacted. Rita, I don't know whether that will come out when I've done I'll send a feedback form out, and yeah, more than happy to be contacted.
Thank you, and thank you, everybody. Thank you for taking the time.